Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another lecture. Today we are talking about the ultrasound biometry. So what is biometry? As the name suggests, biometry is the method of applying mathematics to biology. The term was originally used for calculating the life expectancy. However, in the field of ophthalmology, it deals with the intraocular lens power calculation. The total refractive power of the eye primarily depends upon the corneal power, it depends upon the lens power, the media, and the axial length calculation. The present day cataract surgery doesn't just aim at removal of the cataractous lens, but also at the implantation of the intraocular lens and giving the patient excellent refractive outcomes. All this is going to depend upon our calculation of corneal power, lens power, media, and the axial length. With the technological advancement in the cataract surgery and introduction in the premium IOL, patients' expectations have actually risen, and therefore now they aim at getting no refractive error following the cataract surgery. Any refractive error is no longer tolerated. And therefore, it's very important that we carry out our IOL power calculation and biometry accurately. Let us consider what are some of the prerequisites for IOL power calculation. In biometry, we measure the axial length, we measure the central corneal power, we also measure what is known as the anterior chamber depth. Apart from this, other things which are also measured are the lens thickness, the effective lens position, also known as the ELP. Then we have the wide to wide width. Then we have corneal thickness known as pachymetry. Now let us discuss how much these factors account as the sources of errors in the intraocular lens power calculation. The first one is the prediction of the effective lens position. And if you actually observe, this contributes to the maximum percentage responsible for inaccuracy in the IOL power calculation. Then we have the post-operative refraction. Then we have the axial length measurement errors accounting for 17% of the inaccuracies. Then we have the keratometry measurements. A 0.01 millimeter error in the axial length calculation in an eye which has an average axial length will lead to a post-operative refractive error of about 0.25 diopters. So what you can say over here is that 1 mm error in the axial length will lead to about 2.5 diopters of post-operative refractive error in an eye which has normal or average axial length. Next, if you consider the corneal power errors, if you do a corneal power error of about 1 diopter in an eye with average length, the post-operative refractive error would be about 1 diopter. Okay, so remember, a 1 mm error in the axial length will lead to about 2.5 diopters of post-operative refractive error, and 1 diopter error in the corneal power will lead to post-operative refractive error of about 1 diopter. Okay, remember that. Let us talk about the normal axial length. The normal range of axial length is about 22 to 24.5 millimeters, and the average is 23.5 millimeters. This is important to know because in eyes which have longer axial length than the average, these eyes are much more forgiving. For example, if you take an eye which is about 30 millimeters long, in that eye, a 1 millimeter error in the axial length will lead to a post-operative error of about 1.75 diopters compared to the 2.5 diopter error that occurs in an average length eye. Okay. Smaller eyes are least forgiving. For example, in an eye which is about 20 millimeters long and there is an error of 1 mm, the post-operative refractive error is going to be much more. It is about 3.75 diopter, which is much greater than the 2.5 diopter error which was occurring in a normal axial length eye. Okay, so what you can remember is that the errors are more in smaller eyes compared to the average eye compared to the longer eyes, and the longer eyes are the most forgiving. Now, whenever we are doing axial length calculation, you always have to obtain the data from two eyes, and if the inter-eye difference of the axial length is greater than 0.3 millimeters, then you have to be suspicious. We'll talk about this in a while. First, let us try to discuss now the types of biometers which are available. Based on the energy that you're using, we have two types of biometers. We have an ultrasound biometer and an optical biometer. In ultrasound biometers, we are using the sound waves, and in optical biometers, we are using what is known as the light source. Okay, light as a source of energy. Now, ultrasound biometers again are of two types. So we have contact biometers in which the probe touches the cornea directly, and we have a non-contact biometer in which the probe doesn't touch the cornea directly. Instead, the probe is actually immersed in a scleral shell which is placed on the cornea, and therefore this type of ultrasound biometry is also known as the immersion or non-contact biometer. Okay. Let us see what are the types of optical biometers which are available. So we have those which are based on the principle of partial coherence interferometry, that is the IOL Master 500. We have those which are based on the optical low coherence reflectometry, like the Lenstar 900, OA 2000, Galilei G6. Then we have swept source OCT like the IOL Master 700. Now, for the purpose of this video, we shall be limiting ourselves to the ultrasound biometers like the contact and the immersion biometer. A very important point that we must remember is that the ultrasound biometers doesn't really measure the corneal power, okay, unlike the optical biometers. So whenever you do an optical biometry, you don't need to really measure the corneal power separately. The biometer does it for you, right? Whereas when you do an ultrasound biometry, you actually need to separately calculate the corneal power using a keratometer or a topographer. Now we have a series on topography available on our channel, in which the first video is on the basics of corneal topography, then we have on the maps, and then we have on how to read a corneal tomography printout. Alright, so you can check the links which are present in the description box. Next, let us talk about how the ultrasound biometers actually work. So they're basically working on the principle of piezoelectric effect or piezoelectric effect, however you want to pronounce it. Now, the Greek word piezo basically stands for to squeeze or to compress, okay? And piezoelectric effect basically means mechanical deformation of a piezoelectric material always leads to generation of electricity. So there are certain materials like the quartz, okay? And what's going to happen in these materials is that whenever you apply force to deform these materials, either squeeze them or compress them, it's going to lead to generation of electricity. And also vice versa is also true. So what I mean to say is, if you apply electricity to such materials, it is going to lead to the mechanical deformation of these materials, right? So this is known as the piezoelectric effect. Now this is important because the ultrasound probe actually is made up of these piezoelectric crystals, and these piezoelectric crystals, whenever there's application of external electric energy to this probe, they will start vibrating, they will get deformed, and as they get deformed and they start vibrating, they will generate these ultrasonic waves, right? So these ultrasonic waves are now going to travel inside the eye, and now they will get reflected from the various structures that these waves are going to encounter, like the cornea, lens, vitreous, retina, and the sclera, and then they will be reflected back in the opposite direction to the ultrasound machine. And now, since the machine is again getting some sort of energy, the piezoelectric crystals are going to again vibrate, and now they are going to give us what is known as the echoes or the spikes, right? Now these echoes and spikes are going to be recorded on the screen, right? So you can see clearly how the ultrasound works on the principle of piezoelectricity. All right. So you can see a probe over here. So this probe is going to continuously, is going to send these ultrasonic waves. Now, one important point that you should know is that these waves are traveling at a particular velocity. Okay, so sound has this velocity, particular velocity in various media in the eye, right? And these waves are taking a particular time period for traveling towards the object and coming back from the object to the probe. right? The machine is basically going to operate in this pulse system. Now, pulse system basically means that the probe is vibrating for some time, it's pulsating for some time, and then it takes a pause, right, for a few microseconds, so that all these returning echoes can be received by the probe tips, and it is during that time that these signals are going to be converted into spikes or echoes, right? Now, usually the audible frequency to a human ear is about 20 to 20,000 hertz, right? However, you can see the frequency which a probe uses is about 10 megahertz, right? So it's a really high frequency, and the advantage of high frequency is that it offers higher resolution. All right. Now, the sound is going to travel at a particular velocity within the eye, and we know that the waves are coming back towards the probe. They are taking some time to go towards the object and some time to come back towards the probe. The machine is going to calculate all that time, and once it has calculated that time, it is going to use this formula, that is speed into time equals distance. And it is by using this formula, the machine is going to calculate the various distances like the axial length, anterior chamber depth, and the lens thickness. Okay, so I hope you understood how the axial length is calculated by the machine. All right. Now, let us talk about some other principles of the ultrasound. You should know that the sound usually travels faster in solids compared to liquids. Okay, and therefore the velocity of the sound waves as they are going to travel within the eye is constantly changing. In an SCAN biometer, the sound is traveling through the solid cornea, then it has to travel in the liquid vitreous, then it has to travel again in the solid lens, again it travels in the solid or the liquid, or you can say semi-fluidic vitreous, again it travels in the retina, choroid, sclera, and finally into the orbital tissue. And therefore, we can say that the velocity of the sound waves within the eye is also constantly changing. Right? So you can observe over here the speed of the sound waves within the cornea is about 1641 meter per second. In lens, again, it is somewhat similar. In the aqueous humor and in the vitreous humor, because they are more liquidy compared to the cornea and the lens, and therefore the speed over here is about 1532 meter per second. Now, usually the machine averages these values, and therefore the average sound velocity in a normal phakic eye is about 1550 meters per second. Okay. Now, the cornea is not routinely factored in because the thickness of the cornea is really less, about 0.5 millimeters, and therefore the cornea, the velocity of the sound in the cornea is usually not factored in. Now, the average sound velocity in an eye which does not have the lens, that is an aphakic eye, will come to about 1532 meters per second. Okay. Now, what about the average sound velocity in a pseudophakic eye? Now, we know that pseudophakia means presence of an intraocular lens. Now, intraocular lenses again could be of various materials, and therefore the average sound velocity in a pseudophakic eye is going to be 1532 meters per second plus or minus the correction factor for that intraocular material. Okay, so we'll talk about the correction factors also in a while. Now, a very important point that we must all know is that within the eye, we have various interfaces. That means, for example, the air and the cornea is one interface, the cornea and the aqueous is one interface, between the aqueous and the lens is another interface, and then again between the lens, vitreous, retina, and sclera, there are different interfaces, right? So the echoes are received back into the probe after being reflected from these interfaces, and these echoes are going to be converted by the biometer into various spikes which are arising from the baseline, as you can see over here. The greater is the difference between the two media or at each interface, for example, between the aqueous and the lens. The greater is the difference in these two media at the interface, the stronger is going to be the spike and the stronger is going to be the echo, right? And if the interface difference is less, the echo is going to be weaker. And the strength and the weakness of the echo basically is represented in the form of amplitude. Okay, so what you are doing in a biometer is an SCAN that is, and over here A basically stands for the amplitude representation of the echoes along the path, and it is a one-dimensional representation. Remember that. Alright, so now let us talk about these various types of ultrasound biometers. So we have the contact biometer and the immersion or non-contact biometer. So let's see first about the contact A-scan, also known as the applanation A-scan or biometry. Now the term applanation, I personally don't like to call it that way, because ideally speaking, you're not supposed to applanate when carrying out a contact A-scan as well. You're just supposed to touch the probe to the patient's eye. Okay, compression or any sort of applanation will lead to inaccurate readings in contact biometry. Alright, the patient could be seated or the patient could be lying down, supine position. You have to instill a topical anesthetic solution, and what you have to do is you have to give the patient a fixation target like this. Okay, and then the examiner has to gently touch the cornea without causing any indentation. Okay, and as you do so, there will be generation of these spikes, as you can see. Right, the first spike is coming from, as you can see, from the cornea and the probe. Since the probe is in contact with the cornea, you get the first spike. Then you get one spike from the anterior surface of the lens. Then you get another from the posterior surface of the lens. Then you get one spike from the retina and one from the sclera. Okay, let's talk about that. Now over here, the patient could be sitting or the patient could be lying down, but make sure that the plane of the iris is parallel to the floor. There should be no pillows or no headrest below the patient. Okay, and always make sure that you give the fixation target to the patient. When carrying out the contact biometry, make sure that you hold the probe from the wire. Okay, this actually reduces the compression force on the cornea. If you're going to directly hold the probe from the end of the probe, there are more chances that you might actually compress the cornea. Okay, always make sure you give the accurate or adequate target. Like the patient can use his own thumb, or you can give a fixation light as a target. And even the A-scan probe comes with a fixation light. Usually it is red in color, so you can ask the patient to look towards the light. Alright, now a high quality contact A-scan of a phakic eye basically consists of 5 high amplitude spikes. Okay, remember, now you might say there are so many spikes over here. Yes, they are, but what is important for us are the high amplitude spikes. So we have 5 high amplitude spikes. You can see the first one, which is coming from the cornea and the probe together, because the probe and cornea are in touch with each other. Then we have the one which is coming from the anterior lens. Then we have one coming from the posterior lens. Then we have the spike which is coming from the retina, and spike which is coming from the sclera. So all these are high amplitude spikes. Then of course we have smaller spikes which are coming from the orbital tissues. Another thing you should note is that all these spikes have to rise steeply from the surface, especially the retinal spike. If you see, it has to make this 90-degree angle. Also, there should be good resolution, and these spikes should be separate. There should be no intermixing of the retina and the scleral spikes. So that is very important. So spike height or amplitude is what provides us the information on the about the quality of the A-scan. And therefore, since we are basically relying our biometry on the amplitudes, and therefore this type of biometry is known as an A-scan or an amplitude scan. So I hope that is clear. Alright, so now let us talk about the immersion or non-contact biometry. Now over here, what you can see is that there is a sort of a shell that is placed on the cornea, and this shell is known as the prager shell, or you can call it as a Hansen shell. The purpose of an immersion biometer is that it avoids any corneal compression, because you can see there's some sort of distance between the probe and the cornea over here. Okay, and therefore you're going to see many spikes here. You are going to see a spike that is separately coming from the probe. Then you see a corneal spike. The corneal spike seems to be having these two peaks. Then you have an anterior lens spike, a posterior lens spike. Then you have a retina spike and a sclera spike, and of course the orbital spike. Okay, so in this also, you make the patient lie down supine. Make sure there's no pillow underneath this, and also you have to again put anesthetic drops. Okay, make sure you avoid corneal compression. Obviously, this will be avoided in case of this immersion biometer. ask the patient to fixate, align the probe with the optical axis, and now you have to observe the various echoes and the spikes which are observed. Okay, so over here the scleral shell is known as the Hansen or the Prager shell, and it is usually filled up with saline. You have to make sure that no air bubbles enter the saline, and the probe should be immersed in the saline, and it should be about at a distance of about 5 to 10 millimeters away from the cornea. That is very, very important. Let us try to observe the various waves that we see in an immersion scan of a phakic eye. So over here, instead of 5, you're going to see 6 waves. So the first one is coming from the probe. The second one is from the cornea. Then you have from the anterior surface of the lens, the posterior surface of the lens, the retina, and the sclera. Of course, there are some lower amplitude waves as well. These might be coming from the vitreous degeneration or structures present within the vitreous. Then over here, you have smaller wavelets which are coming from the orbital fat. Now, two important things that you have to remember which differentiates it from a contact biometer. In an immersion scan, you have the separate probe and corneal spikes. The corneal spike over here demonstrate 2 peaks. Okay, you can see this is bifid. So the first one is actually coming from the epithelium and the second one is coming from the endothelium. And you have to also note that these 2 spikes which are coming, the 2 peaks of the corneal spike, they should be of equal amplitude. In any case, if these are not equal, this should actually raise suspicion that the probe is not aligned through the corneal vertex. Alignment of the probe is really, really important, whether we are talking about contact biometry or the non-contact biometry. So let's see why that happens. So if you're going to align the probe basically like this to the, whenever the probe is nicely aligned, parallel to the visual axis or coaxial to the visual axis, what's going to happen is that all the sound waves which are traveling from the probes, they're going to be reflected and they're going to be traveling parallel to the visual axis, and all of them are going to be received by the probe. And since all the sound wave is received by the probe, the spike amplitude is also going to be good. However, if the probe is not aligned correctly, the waves are going to be incident in an oblique fashion, and therefore some of the waves which are reflected, they are not going to make to the probe, and instead they are going to be reflected outside, and this will lead to compromised amplitude or compromised signal in the SCAN biometry. Okay, and therefore it is very important that the probe is oriented nicely parallel to the visual axis at the corneal vertex. Okay. Next point is regarding the shape and smoothness of the interface. Okay, I already told you what exactly is meant by an interface. So over here, we are talking about the macula. For example, when the macula is smooth, okay, all the waves are going to be reflected nicely parallel to the visual axis, and they're going to be received by the probe, and therefore the amplitude is going to be nice and smooth. Okay, big, nice amplitude. However, if the macula is not smooth, for example, if there's any irregularity in the surface of the interface, like if there is any macular edema, if there's pigment epithelial detachment, or if there's any epiretinal membrane, what is going to happen is that there's also going to be reflection away from the probe. Sometimes there might be refraction of the returning sound waves away from the probe, and therefore a few waves only are going to make up to the tip, and therefore it will lead to weaker echoes or weaker signals or low amplitude spikes. Okay, and therefore in order to get a correct biometer readings, it's very important that you have a normal macula as well. All right, for example, over here, you can see this is basically a good retinal spike. A good retinal spike should actually rise sharply like this. It should be at 90 degrees angle. All right. Now, let's talk about the concept of sound absorption. Now, we know that sound is basically absorbed by everything through which it passes before it travels to the next interface. So, the greater is the density of the structure through which the sound is actually passing through, greater is going to be the amount of absorption. And therefore, in a case of extremely dense cataract like this, great amount of sound energy is going to be absorbed, and there will be attenuation of the signal that you're going to get on your display. Okay, and that is the reason why in case of an extremely dense cataract, you're not going to get really high amplitude retinal spikes, because the lens is going to absorb most of the sound energy that reaches the retinal surface. Okay, so over here you can see the waveforms are quite shrunken, actually you can see over here multiple internal spikes. You don't have those classic 5 spikes that you see, and this happens because of the various refractive indices which is present within the lens, and the lens is also absorbing most of the sound energy, and therefore you're not getting you're not getting the proper morphology of the spikes, right? So that is one problem that can occur when you're carrying out biometry in case of the dense cataracts. Now, this brings us to the concept of gain in ultrasound. So when you're getting this dampened signals because of a cataract, is there a way that we can amplify the signal? Yes, you can amplify the signal by increasing the gain, right? So gain is that property which is measured in decibels. It is basically the amplification of the ultrasound signal that returns to the transducer after passing through the tissue. Okay, so in cases of dense cataract, we might need to increase the gain. These higher gains will lead to increased amplitude. It increases the sensitivity. But the only problem over here with increased gains is that since the machine has now become more sensitive, there's going to be more noise as well. And therefore, you're going to suffer in terms of resolution. However, in certain cases where there is aphakia, where there's no lens to actually absorb, you don't need that much amount of signal, and there you can actually reduce your gain. So in aphakic patients, you can actually go for a lower gain setting. Now in the first picture, you can see the gain is too high. So when the gain is too high, the machine has become more sensitive and it's picking up every random signal, and therefore you can see there's a lot of noise over here. Instead of seeing two spikes, one from retina, one from sclera, we are seeing this broadened, thickened spike with a flattened peak, right? This indicates that there is too much gain. So when there's too much gain, you're going to get a strong signal, but the resolution is going to be poor. Now, in such cases, you have to actually reduce the gain until the retinal and the scleral surfaces are seen as separate spikes, okay? So if you reduce the gain, the resolution is going to be good, but the signal is going to be weaker. Okay, so you really have to decide what exactly you want. Now, ideally, the retinal and the scleral spike should be separate. And if you're carrying out an immersion scan, the peaks of the corneal spike, that is one coming from the epithelium, one coming from the endothelium, they must also be separate. If there's any fusion between these two, then also it's an indicator that you have to reduce the you have to actually reduce the gain in order to separate these two peaks. All right, now let us talk about the concept of electronic calipers or the gates. Okay, we all know what calipers are. So calipers are something which are used to measure the distance between 2 points, right? So electronically also the machine introduces these gates. So gates are these electronic calipers on the display screen that measure between the 2 points. Okay, so biometers are designed so that between each pair of the gates a measurement is rendered. For example, the biometer is going to automatically place a gate over here near the probe and the cornea. Then it's going to place a gate where it believes that the lens is spiking. Lens anterior surface is spiking. Then it's going to place a gate somewhere near the posterior surface, a gate near the retina, a gate near the sclera. Okay, so the biometer automatically places the gate on what it believes to be the central corneal spike, anterior lens spike, posterior lens spike, retinal spike, so on and so forth, right? And it is also programmed to measure the distance between each of these pairs at a given velocity, right? So the ultrasound is actually going to place these gates automatically, and also it is at these gates that it is going to record the time taken for the sound to travel from one point to another, and then the machine is going to use this formula, distance equal to velocity into time, and it's going to calculate the various distances between these gates. And of course, we know how the velocity at various parts of the eye is, right? Similarly, you also know about the average sound velocities in the phakic eye, aphakic eye, and in the pseudophakic eye as well. Now, if you know that the average sound velocity in phakic, aphakic, and pseudophakic eye is, you should also know that there are various modes which are present within the biometer machine. So in these modes, you can actually choose whether you are dealing with a phakic person, that is normal person, or you're dealing with an aphakic person, or whether you are doing a biometry in a case of a patient who already has an IOL inside him. So that is known as a pseudophakic eye, right? So again, within the pseudophakic eye, there can be various settings which can be available. So there might be a setting for the material. That means you might be able to choose whether the material is PMMA, acrylic, or the silicone, right? So now, when you carry out a biometry in case of pseudophakic eye, you might actually be able to see a lot of these spikes. These spikes basically are known as reverberation artifacts, and these are more prominent when the intraocular lens is basically of PMMA variety, right? So a PMMA lens is going to, or an intraocular lens is going to give more reverberation artifacts compared to a foldable IOL, which is made up of usually acrylic or the silicone, right? So you can see in the second picture, there is a foldable or IOL which is used, and therefore the reverberation artifacts are much less over here. All right. So I was talking about the correction factor. Now this is used when your biometer doesn't have a pseudophakic setting or just has a PMMA setting. Now in those cases, what you can do is you can actually put the mode as a phakic mode. Okay, and then you can calculate your axial length using the ultrasound biometer. And after you have calculated the axial length, you can actually add up the correction factor. For example, if your patient has a PMMA intraocular lens inside the eye, you will carry out the biometry in the aphakic mode, and the axial length, say, comes as 23 millimeter. Now, in this person, the correction factor is plus 0.4 millimeters, and therefore, the corrected axial length in this patient would be 23 plus 0.4, that is 23.4 mm. Okay. Similarly, you can carry out the correction factors for silicone and also for the acrylic. Now, let me tell you that if you already have the settings for silicone and acrylic IOL, then you don't need to take these correction factor into consideration. All right. Now, sometimes there might be a patient who might be having a silicone oil inside the eye. Now, silicone oil also can change the sound velocity, right? It has high density. And for example, we have 5,000 centistrokes of silicone oil available, in which the velocity of the sound is going to be 1040 meters per second. And then we have 1,000 centistrokes where the speed of sound is about 980 meters per second, right? As you can see, the sound waves are traveling slower in the silicone oil compared to the normal eye, and therefore if you don't really use proper settings within your biometer, the axial length that the biometer is going to measure would be erroneously long axial length. All right, so that's one important point that you must remember. The silicone filled globe is going to lead to a false long axial length measurement. Now let us talk about some common errors and challenging situations while you're carrying out an ultrasound biometry. First thing first, whenever the inter-eye difference is greater than 0.3 millimeters, and when the consecutive same eye readings are different by more than 0.1 millimeter, then in those patients you have to be suspicious. The first thing that you should do is you have to consider the medical history of the patient and find out if there is any particular reason as to why there are differences in the reading. The patient might be having a macular pathology. The patient might also be having some problem like posterior staphylomas, which is going to give different readings within the same eye. All right. Another common source of error, which is also the most common error seen in contact technique, is the corneal compression. Okay. So remember, corneal compression is seen in the contact technique of biometry. Now, this happens because the eye is really soft and pliable, and the cornea can be indented with minimal pressure also from the probe tip. And as a matter of fact, the softer the eye, the lesser the intraocular pressure and the greater is the compression. It's more easy to compress a softer eye compared to a hard eye, and this will lead to the problems within the axial length measurement. Now, since corneal compression is going to compress in the cornea, the anterior chamber depth measurement is also going to go down. And therefore, in these cases, it's very important to keep an eye on the anterior chamber depth. If the depth is less, you know that there is some sort of corneal compression which is going on. And therefore, anterior chamber depth must always be monitored, and all the readings with a shallow anterior chamber depth must be deleted from your measurements. Next error is the misalignment of the probe. I already told you that it's very important to keep the probe perpendicular to the corneal vertex, and the rays have to go and strike perpendicularly to the macular surface, okay, so that the rays are directed parallel to the visual axis. This perpendicularity is achieved. Whenever this perpendicularity is achieved, the retinal spike and the scleral spikes will be of high amplitude, and the retinal spike will arise steeply from the baseline. Make sure that there are no slopes, no jags, no humps or steps on the retinal spikes. Over here, you can see that this retinal spike is slightly sloping, and therefore this indicates that your alignment of the probe is not correct. There's some misalignment. So you need to take another reading by proper placement of the probe. Now, sometimes the probe might be misaligned at the lens surface. Okay, so normally you have the anterior lens spike and the posterior lens spike. So over here you can see this is the anterior lens spike, and this one over here is a posterior lens spike. Normally they should be of equal amplitude. If they are not of equal amplitude, it means that again the rays, the sound waves are not striking the lens appropriately. That means there is some sort of probe misalignment, and therefore you need to correct your positioning. Now, sometimes the probe can be misaligned in such a way that the rays or the sound waves are going to travel through the optic nerve instead of traveling to the center of the macula, right? Now, in such a case, what is going to happen is that there will be absence of the scleral spike. Now, why does that occur? We know that the optic nerve basically is actually a bundle of nerve fibers, and there's no sclera present within the optic nerve. And when the sound waves are going to travel through the optic nerve, they're not going to encounter any scleral spike. Now, we don't want that. We basically are measuring the axial length, which is from the corneal vertex up to the internal limiting membrane in case of ultrasound biometry. And in case of optical biometer, we are measuring it from the corneal vertex up to the RPE. So all these measurements are taken at the macula, right? And therefore, whenever you see a waveform like this where the scleral spike is absent, in those cases, you should know that there is misalignment along the optic nerve. All right. Another thing is that make sure that there is no no thick gel sitting on the patient's eye, because then there's going to be a meniscus between the probe tip and the eye, and you are going to get a falsely long axial length. Now, another problem that occurs while measuring the axial length is extremely variable readings that you get in case of posterior staphylomatous patients and in high myopes. Now, in high myopes, the globe is elongated and the uvea can actually bulge into the sclera, and this happens mostly posteriorly. Now, in these cases, the macula has a sloping edge, and as I told you that the regularity and smoothness of the interface is very important in order to get good waves. Now over here, because there's a sloped configuration of the macula, there will be variable reflection of the sound waves, and therefore the waves that you see over here would be of poor amplitude, there will be poor configuration, morphology, and extremely variable readings. It's always better to carry out an optical biometry in case of posterior staphylomatous patient. However, if that is not available, you can carry out an axial length measurement in a B scan as well. So in a B scan, you do a horizontal macular scan with the probe mark present directed nasally, and the axial length will be measured from the corneal vertex up to the macula. Over here, what you see is the optic nerve void. So you take a reading 4.5 millimeters below the optic nerve void, and this is how you can get the axial length measurement in a case of posterior staphylomas. Now we have videos on B-scan ultrasound as well on our channel. The link is going to be provided in the description box. Now let us talk about some of the advantages of an immersion scan over the contact scan. So here it is more accurate than a contact scan because the corneal compression is something which is avoided. Moreover, you will note that the immersion method axial length are about 0.1 to 0.3 mm longer than the contact method because, of course, the compression of the cornea is avoided. Moreover, the probe and the corneal spikes are separate, so you can study the corneal spikes well. The cornea has two spikes over here, okay? That is one from the endothelium, one from the epithelium. It's a faster method, and moreover, it reduces the technician dependency. Now, it doesn't mean that the contact biometer is useless. Actually speaking, in good hands, it actually can give you really good values and really comparable values. But when the technician is not as experienced, and therefore in those cases, immersion scan or an optical biometer is much better choice. All right, so that's all for today. I hope you enjoyed the video. If you did, don't forget to subscribe to our channel. It really makes a difference. And that's all. Thank you and have a nice day.